Hello, everyone. This is Nayiri from Low Carb and Fasting. Now, my guest today is a board-certified cardiologist. He's also a functional medicine doctor. He's passionate about health and fitness and improving people's health and fitness through lifestyle interventions. And he is the medical director of one of the world's largest sites or diet or health related sites called the Diet Doctor, which you might be familiar with because I do make references to the site quite often. And he's also the author of Your Best Health Ever, the cardiologist's surprisingly simple guide to what really works. Dr. Bret Scher, welcome to Low Carb and Fasting.
Thank you so much for having me. It's a pleasure to be here today.
Yeah, the pleasure is mine. Thank you for accepting my invitation. Dr. Scher, so you were classically trained as a cardiologist.
Yeah, not only that, I was trained in an Ornish style cardiology prevention program that, focused on a lot of great things, getting people to stop smoking, getting them to exercise, working on stress management and community building, and a very low fat vegan diet. That's how I was trained.
But I think, I am sorry that I haven't read your book, but I did order your book. So as soon as it comes, I am going to order. But you say the cardiologist's guide to what really works. So what really works? What works?
Yeah, well, I'm not going to give away the whole book, right? No, just kidding. What works is focusing on nutrition, exercise, stress management, understanding why you want to be healthy. It's a multi-legged stool, but the thing is there's not one thing that works. And I think that's part of the key, right? It's not just eat this one diet and that's takes care of everything. And that's really the fallacy of a program like the Ornish style program, that it's the vegan diet is going to cure you. Well, no, people stopping smoking, having their cardiovascular risk factors aggressively assessed and treated, exercising, it's a multi-modality approach. And many different dietary interventions can work for different individuals. But a big part of it is, what diet are you going to stick with? Food is so much more than just health and energy. And it'd be a lot easier if that's all it was. But it's enjoyment, it's pleasure, it's socializing, it's families, it's our history, it's our ethnicity. So much of that is enrolled in food. So to think that we can prescribe one diet for the whole world or even one country to eat is just a complete fallacy and doomed to failure, which is exactly what we've seen over the past 50 years of trying to, teach people to eat one diet. So there are a lot of different approaches. You have to find the approach that's going to work for you, but with certain parameters, right? Ones that are going to help you eat less naturally, ones that are going to give you plenty of protein, and ones that are going to improve your metabolic health. Because when it comes to metabolic health, nutrition is probably the single most important thing you can do. So you need to find a dietary approach that can fit those things. Now, a low carb diet tends to hit all those parameters and can have multiple different facets or different versions of a low carb diet to fit people's taste, to fit people's ethnicities, to fit their culture and their background and so forth. So that's why I am a big proponent of low carb diet, but it's not one thing. It's many different versions of it.
Yes, there are many different versions, higher protein, lower protein, higher fat, lower fat. But I think it comes down to lowering the carbs. As soon as you start lowering or eliminating the processed carbs to start with,
sure,
lowering your carbs generally, the rest don't seem to have that much impact. Or the rest can be individualized. Do you agree? Because people are all different. I mean, even I personally have shifted from high fat to lower fat, higher protein, lower protein. I shift the other two, but the carb level, I just can't afford shifting that because that has an impact on my type 1 diabetes, but I should think it's the same for type 2 diabetics, for example, right?
Yeah, I think it's pretty clear. The more insulin resistant you are, the more you're going to benefit by strictly limiting the carbohydrates. And then as you become less insulin resistant or more insulin sensitive and improve your lifestyle, then you can generally get away with adding more carbs. But that doesn't mean you start adding back the potato chips and the refined white flours and the sweets and all that, right? Within that just doesn't have any place in a healthy dietary matrix. But adding, more fruit, more sweet potato, even some legumes, those types of things can have a role as your metabolic health improves, no question about it. But for those people who are most severely insulin resistant, that's where a strict low carb with higher fat is certainly beneficial. I think in the beginning, I think for a number of people, and again, there are individual variations, but a general concept is to transition into a low carb diet with high fat because it helps you with the transition. And then maybe over time, start to adjust to a lower fat version, not low fat, not like 20, 30% fat, but maybe like, 60, 65% fat as opposed to 80, 85% fat, like that type of version.
Mm-hmm. This is exactly what I did because I don't have any weight to lose.
Mm-hmm.
So I have to be careful. I have to adjust my fat intake because I quickly gain weight, but I'm at my ideal weight now. So I don't want to lose weight.
Right.
So I have to keep adjusting the fat. If I've overindulged in cheese, for example, for a week, which is what I did over the past week, being in California, I wanted to try everything I could see, every product. And so now I know I have to do fasting. Now fasting is my next question, which is what I'm doing now. So I decided that's it. Now I'm going on a 36-hour fast, which something I've done before. So what are your thoughts on fasting, or extended or intermittent? But let's start with intermittent fasting.
Yeah, fasting is another really interesting topic. And just like with diet, just like we can't say, here's the one diet for you, we can't say everybody needs to fast and here's how you do it, because people react differently to fasting, and when I first started to investigate fasting and kind of get into it, I was like, yes, everybody's got to fast, time restricted eating for everybody, everybody's got to be on an 18-6 and do an alternate day fasting, one day a week. And then as I started to get more experience with it and some of the new literature came out, I realized that there is a subset of patients, a subset of people who is not small. I mean, there's a sizable group who actually have sort of a negative response to fasting, that whether from a hunger standpoint or a psychological standpoint, they actually sort of eat more calories during the day or eat sort of, you can say, quote unquote, worse foods during the day because of that fasting. It can stimulate cravings, it can stimulate hunger, but clearly not in everybody, right? Because there's this other subset that just does an 18-6 like it's nothing and doesn't even think about it and is much happier and feels better that way. So I think the most important thing is sort of experimenting with fasting and deciding which group that you're in. Not that you're always going to stay in that group, but that's the group you're in sort of at the moment. And maybe sometime in the future, try it again. But the other question is, what are the goals of fasting? Are you trying to lose weight? Are you trying to minimize or to lower your insulin? Are you trying to improve your insulin sensitivity, right? There are different goals to fasting as well. So that can decide how hard you should push to try fasting. And whether that's time restricted eating or longer fasting, when you get into longer fasting, now you start talking about longevity, right? So now is there a longevity benefit to it? And, longevity research is so poor and so difficult to do, because how are you going to measure humans for 50, 60 years to see if it's improving longevity? So you either have to work on surrogate markers or animal studies. So there is a bit of a leap of faith, but I think there's something to it. I think, 5-day fast every quarter has some support to say it can improve longevity. So if you're the type of person who can fast without a problem, and you're getting adequate resistance training and protein and have decent muscle mass and lean mass on a regular basis, then doing a 5-day fast once a quarter is probably worth it. But if any of those things are not true, if you struggle with fasting, if you struggle to get enough protein, if you're low on your lean mass trying to improve it, then no, probably a 5-day fast is not in your best interest. So, again, you can't just say one recommendation for fasting. You have to define who it is, what the goals are, and how they react to fasting.
True. I do it for insulin sensitivity. So when I realized like overindulgence in cheese makes me insulin resistant, and it's not like a chronic condition. I know it's temporary, but the way to recover from it is for me to do a longer fast. Mm-hmm. Not necessarily 5-day, but I'm petite, I'm small, so I'm generally very insulin sensitive. So 1 day of insulin resistance, I address it. I don't just leave it, because it could go on and on. It could go on. It doesn't go back to normal on its own. So even if I skip one meal, which is very easy for me to do, like one meal, I skip one meal, And then I realized, oh, blood sugars are back to normal. I'm, maintaining straight line. So, so it is very, depends on the individual. I would recommend it to my elderly mother, for example.
Right. Good point.
Yeah.
And for people with type 1 diabetes, I mean, as you know, it requires very careful monitoring of your blood sugar and adjustment of your medication. So nobody should be doing it on their own. They should be doing it with a clinician to help guide them, or someone who, really understands how to adjust the medications.
True. Well, it's actually very sad that clinicians aren't supporting type 1s who want to do fasting. Not even keto. I mean, forget the fasting. They're not even supporting type 1 diabetics doing keto. And so I set up a group on Facebook, and I found that there are 300 other crazy type 1s out there who are doing fasting just like I did. I thought I was writing blogs and I was the only crazy one, but other people are doing it completely on their own. So we're ending up supporting each other. This is where I think the medical profession is still lagging behind, and it makes me sad.
I agree 100%. And, people like yourself and Dr. Troy Stapleton and Dr. Ian Lake and, other doctors and Dr. Keith Runyon, who promote ketogenic diets and versions of intermittent fasting for people with type 1 diabetes. We need to hear more from them, more voices like that, so we can understand in the right setting, it's absolutely safe, absolutely effective. But again, it's not just something anybody goes and does on their own, because there are safety precautions.
Absolutely. Yeah. CGM is a lifesaver. So, and of course, glucose tabs, which are always with me. And you never know when you're going to go up or down unexpectedly. So nutritional sciences, you mentioned longevity science. I mean, it's at its sort of infancy, right? There is a lot of promising work on it, but we need to give it more time. But generally speaking, nutrition science is very complex, right? Tell us.
Yeah, complex is one word. Complex is one word to use. There are some other less positive words, I guess, you can use too. I mean, it's terrible. Nutrition science is terrible. And we're making decisions about what to recommend for people's health based on some of the lowest quality science. And it just makes you wonder if we're just better off not having a lot of these studies, these multi-center, multi-country observational studies with hundreds of thousands of people, where you control nothing and you just crunch the data and look for associations and say, oh, look, here it is. They eat more red meat, therefore red meat's the problem. Therefore, if you reduce red meat, you're going to be healthier. And when you look at the data and you tear it apart, it has nothing to do with the conclusions, because the people who ate red meat were much less healthy at baseline. They're more likely to smoke. Does that mean red meat causes you to smoke more? Absolutely not. But that's the same thing as saying red meat causes you to have more heart attacks, because there's the same association there. And when you look at these hazard ratios, like how much is the difference? They're like 1.1 and 1.2. And the reference I always like to give, smoking, people say, well, there was never a randomized controlled trial about smoking. Well, no, because the hazard ratio was like 15, 20, 30, depending on the study. Not 1.30, but 30. And here we're talking about 1.1 and 1.2. So they're orders of magnitude different. So, I mean, to try and use that type of data to inform what an individual is supposed to eat is terrible. Like, how could we even assume that that's going to be anywhere near accurate? But yet that's what we're dealing with for the majority of our nutrition science. So it's pretty bad. And we'd probably be better off without the recommendations, without dietary guidelines, without trying to make sense of this data, and instead trying to use higher quality data or use, personal experience more about to figure out what diet works for you, than assuming there's one diet based on these very poor quality trials or studies, not even trials.
I believe you've covered one of those terrible studies in your one of your analytical videos for on Diet Doctor. I think it was about diabetes, and being type 1 diabetic, I'm always fascinated by diabetes in general. And it was a study about, again, red meat could red meat be causing diabetes. But of course, in the conclusion, they do mention that, oh, mind you, the red meat eaters were also eating the bun with it. We're also eating the French fries, and we're drinking more Coke and eating more pastry. And so, are biases also playing a role here?
Sure. Absolutely. And, let me clarify one thing. I said it's terrible science. And what I really should say, it's a terrible use of science, right? The study is what the study is. Not like the researchers did anything wrong or they conducted the study poorly. It's just a misunderstanding of the strength of the study and how to use it to inform individuals. So that's the terrible part. I don't mean to put down the scientists doing the work. It's the interpretation and the use of the science that's the problem. And that's exactly where biases come into play. Because if you find a low quality study that fits your bias, it's really easy to ignore the fact that it's low quality evidence because it fits your bias, confirmation bias, let's go, I was right all along. Versus if you find a low quality study that goes against your bias, then you tear it apart and say how low it is. I've done that. I can own that. I've done that for sure. So I think that happens all the time, and we all have to be much more self-aware about that, about what our biases are. And that would help us, I think, interpret the science with a little bit more attention to the quality of the science and understand that the strength of the recommendation needs to match the strength of the science, and that's frequently not the case.
Yeah, so even control studies, clinical control studies, even those can be, the data can be misinterpreted or manipulated. Any thoughts on that?
Yeah, randomized controlled trials are a higher level of evidence, but how you design the trial makes a difference, right? Is it only 18-year-old healthy males in your study, and then you're going to try and apply the results to a 50-year-old female with type 2 diabetes, right? Like, look, the randomized controlled trial says this works. Yeah, but it worked for what and in whom and what duration of time? And then does that relate to the population you're talking about or the individual you're talking about? So even though it's a higher level of evidence, it still can be really misinterpreted. So you need to know exactly how it was designed, what was the question, what was the population, and what was the result. Like, all that matters. It's a lot to ask people to do, right? People who don't have training in medicine and science and nutrition, it's a lot to ask them to do to interpret this. So it's up to us as clinicians, as educators, as voices in the nutrition community to try and be as open and honest and critical as we can about these studies so people can understand the differences.
I was just about to ask, how does a layperson with no background in science or nutrition trust what they read? Because
Great question.
the media headlines, people don't even read the full article, let alone going to the study and trying to interpret the study themselves.
Yeah.
But it's just the headline, and the headlines are sensationalized, and they really don't do the studies any justice by, it's difficult to get through to lay people without a background in science.
Yeah, it's depressing to think about, isn't it? Like, it's really depressing, to see what we're up against and what the average person is up against is a little disheartening. And that's where, I just encourage people to find that selection of voices of people that they can trust and that they have a good track record and that they can believe and that is critical about the details, and follow them and try and hear more about what they have to say, and hopefully that can help. And the basics, though, of just not falling for nutrition epidemiology studies as being, something that really you should pay attention to as an individual. That's like a basic thing. But then it's really about finding those trustworthy voices and following them. And that's what I hope to be for some people, and what Diet Doctor hopes to be for many people, to really be that source of trustworthiness.
You did mention in the beginning that sort of a diet, generally low or lower carbohydrate diet, free of processed foods, a diet that controls your hunger is generally a diet that works. Yeah. Let's talk about hunger and satiety on the other side. So is it protein or is it the fat? Because it seems to vary with people.
Yes.
It's different for people, and I know that it's different for me as well. That said, it does tend to change. Maybe it's hormonal. I don't know. I haven't figured it out. I'm approaching 50, so maybe it is kind of governed by my hormones. And I know that there is a link between obviously insulin and ghrelin, for example. So I know how to control my hunger on different days or at different times in the month. But generally, which one is it? Is it the fat that causes the satiety, or is it the protein?
Well, if you look at the literature that exists, protein seems to have the strongest signal.
Mm-hmm.
Now, again, what are the details? Those are in usually all higher carb, kind of mixed type of diets. So as you go down to a lower carb diet, does that change to some degree? And does it matter where the fat is coming from? And I think the answer to those is definitely yes. So if you're eating a higher carb diet, I think it's well established that protein has the biggest influence on satiety. Not the only influence, but has probably the most significant influence on satiety, and at what level. So the average American is eating like 12 to 14% of their calories from protein. And the studies are pretty clear. If you can increase that to 25%, that you see a tremendous benefit in satiety and decrease in hunger. As you go beyond that into the 30, 35, 40%, you still may see some benefit, but the slope of the curve is much, much smaller. So your incremental benefit, although maybe some in general, is going to be much lower. Now, as you relate that to a low carb diet, does the same thing hold true? Well, there we have maybe one study, and that's about it, which suggests the protein still has a stronger effect than fat, but it's one study, it's a suggestion, it's hard to say. And I do not want to discount the experience that so many people get when they go low carb and they add more fat to their diet, that they just feel incredibly satiated. And when they cut the fat, they feel hungry. Some of that is just plain calories, but some of that is a satiating effect of fat, especially when it comes with protein and fat related foods, right? I mean, it's probably different from a ribeye than it is from olive oil. It's different maybe even from dairy than it is from just, again, like olive oil being the example. So there are different versions of fat too, but I think there's no question fat is a satiating hormone. And I just did sort of a series of different YouTube videos at our Diet Doctor YouTube channel about protein and satiety, energy density and satiety. And then I did fat and satiety, and I'm doing keto and satiety to really kind of talk about some of the specifics for each version of that. And again, to say there's one diet that's going to work well for everybody for satiety is also a little misleading, but we can say sort of in general what works. And I think having a lower carb, moderate protein, moderate fat diet is a perfectly good diet for satiety. Those are all relative terms, of course, but say less than 100 grams of carbs, the 1.6 grams per kilo of your body weight for, or your ideal body weight or reference body weight for protein, and then kind of filling the rest in with fat for calories and to enjoy your meal tends to be very satiating for most people. But you got to start and see how it works and make the adjustments as needed depending on how you react.
Mm-hmm. And we're still learning, right, because there aren't too many studies on low carb eaters, at least long-term studies.
Right.
Because it's a relatively new movement. So, but it's not a new concept. The low carbohydrate sort of diet is definitely not new. I mean, diabetics used to be told to avoid carbohydrates. It's only later on with the insulin being better and more accessible, we were told, well, eat what you want and cover it with insulin.
Exactly.
I tell people I was diagnosed 44 years ago. And when I was first diagnosed, it was a low carbohydrate. No one labeled it as a low carbohydrate diet, but my mother was given a list of foods, rice and bread, and I think certain fruits to limit, and other foods to eat more of. And those other foods actually included meat.
Yeah.
And I don't know, 20 years later, it was, we were told, oh, no, you don't have to worry about eliminating anything, eat what you want. And that my health until I discovered the ketogenic diet. So it's not really the low carbohydrates diet concept, but why is it that we don't have many long-term studies on it? What do you think? I'm surprised.
Well, I think a couple of things. One, even though it's been around for over a century, treating epilepsy even as a medical intervention, it just wasn't popular. It wasn't like super popular until Atkins wrote his book. But the I guess you can say traditional medical and dietary communities always dismissed it because it is unhealthy by definition. There's no need to study it. We know it's unhealthy because it has fat. It has animal products. Therefore, it must be unhealthy. Why even bother studying it? So when you're up against that level of bias, it's no surprise that people didn't study it. One, who's going to fund it? And two, when you go to publish it, is if you have a superior who's helping you publish things, are they going to be interested in that? Probably not, right? So if you're like a PhD student or a postdoc or even brand new on faculty, do you want to create the waves and really upset the powers that be by studying this? So I think that has a lot to do with it, unfortunately. But now we're seeing that tide start to turn. It's both popular and starting to get better understanding about the science behind it, that there is actual science here that we need to look at more carefully because there are definite benefits. And, Virta Health has done a great job in really paving the way for science by doing their own studies that they show can reverse type 2 diabetes. But not just that, they improve symptoms of depression. They decreased inflammation. They reduced their cardiovascular risk. All of these findings came out of their studies that they're doing. And when you see that, that's the impetus to say, okay, we have to study this further because this is a signal we cannot ignore. Yeah.
I remember one of your videos, you were interviewing Gary Tubbs, Tubbs, as you say it. I can't say the American way, but he did mention about the cost of running studies, and he mentioned, I mean, it was tremendous, unbelievable sums he was giving. So let's just talk of that, because that makes everything more difficult, or unbiased studies at least, or studies.
Oh, sure.
Not funded by the pharmaceutical companies, and studies not funded by the food manufacturing or processed food manufacturing companies.
Right.
It's really challenging.
Yeah, it sure does. I mean, it's a very sobering discussion anytime you talk about how expensive these studies are to do. And that's the reality of it. If big pharma's got big pockets and they're going to spend lots of money to run these studies showing that their drug is better, are they going to fund a nutritional intervention study? Absolutely not. And same for big food companies. So our hope is NIH, but those grants are pittance compared to what a trial really costs and what the pharma companies are prepared to spend. And then it comes down to philanthropy, like what Nusi tried to do with a grant from the Arnold Foundation, and then trying to get other donors to help raise money to run these studies. And even that's very difficult. But I mean, hats off to them for even trying. I mean, such a great effort. And there were some studies that came out of it for sure, but not enough, right? We need more of that. And how do we get there? I don't know, but I hope more academic institutions become interested in it. Jeff Volek, Dr. Jeff Volek just got a huge grant from the DoD for to start researching nutrition research and low carb research. So that's a great start. So there's some hope. I mean, it's not all dismal. There's a lot of dismal stuff here when you think about it, but there's definitely some hope that we're seeing some directions for the future.
And perhaps we shouldn't really dismiss smaller scale studies as well, or publicly funded studies, as citizen scientists like Dave Feldman are doing.
Yeah, for sure. So, Dave Feldman gets so much credit for dreaming up the study, organizing the study, recruiting a team to run the study, and trying to go out and actually get funding and crowdsource it. And get patients. I mean, like, such an amazing grassroots effort. Like, that's fantastic. And then again, going back to Virta Health, so like a private industry can do it to show their program works. Or like Dr. Tro published a 10 patient study that he did at his practice. So these types of things are obviously less expensive to do. They take time, they take energy. Not everybody has unlimited amounts of that. But so there are different versions of studies that you can do, but to get the randomized controlled trial with hundreds, if not thousands of people for a number of years, that's cost prohibitive in a number of different ways. So you're right, we should not ignore the other versions of science, and hats off to all those people, whether it's Virta Health, whether it's Dave Feldman, whether it's Dr. Tro, whether it's other clinicians. There was recently a publication about a ketogenic diet for bipolar disorder by this psychiatrist in France who changed the diet for a certain section of the inpatients who are in an inpatient facility for bipolar disorder. So again, he didn't have to spend tons of money for that study. So it's a great example of things that we can do to further the science.
Or even the efforts of, we shouldn't discredit the efforts of the Dr. David Unwin from the UK, who's
Exactly
publishing the data from his own patients, from his own clinic.
Yeah.
Yeah.
He's been doing it for years. I mean, he's been doing it for years now, and right, is not the quality of a randomized controlled trial, but my goodness, it makes you open your eyes and say, hey, he's having some amazing results. Why isn't my doctor getting those results? My doctor should be getting those results too. And so let's learn from what he's doing. Or if you're a doctor saying, I'm not getting those results, so what is he doing that I can change to start getting those results?
Why aren't all doctors open, at least, to the idea of the low carbohydrate lifestyle? I mean, some are so vehemently against it. It's stunning.
Yeah, that's how we're trained. We are trained that fat is bad, and you need to avoid dietary fat. And you need your healthy whole grains and your healthy fruits and vegetables, and those have a health halo around them. And how can any diet that doesn't have those be, that doesn't emphasize those, be healthy? And that's how we're trained. So it's so hard to overcome that incorrect training, but then that just gets ingrained in our belief and our philosophy over decades of practice. And it's so hard to do. I think the other part is, though, like a lot of docs just don't have the time and energy for it. You know, they're overworked, overstressed, seeing too many patients without enough time. And how are you going to completely change the way your patient is eating and educate them in your 5 or 10 minutes that you have with them, when you have to go over their prescription list, where you have to type up their note, where you have to go, you have to check all these boxes for your group for your medical group to get paid properly? Like, that's where the focus is, rather than on the lifestyle changes. And a number of people are just jaded. You're like, I've tried so many times to get people to improve the way they eat and to get them to exercise, and it doesn't work. Why waste my time if it hasn't worked? Well, maybe it's part of the message. Maybe it's the message that's been wrong, and changing the message can help people with compliance and seeing results. A lifestyle that helps you see results quickly, you're much more likely to stick with than ones you don't see results with. So all those factors come into play. There's a lot there to unpack for sure.
Mm-hmm. And that's an interesting point you made, but also probably lifestyle that people can stick to. Yeah.
I mean, I can't tell you how many times patients come back for your 6-month follow-up. Oh, how are you doing with the diet and the exercise we talked about? No, hated it, couldn't do it. And like, all right, check. I tried, he failed. Here's your prescription, right? Like that. I'm embarrassed to admit it. I did that so many times, and it took a number of years for me to realize, wait a second, something's wrong here. This is not the way it's supposed to be.
Mm-hmm. So I've invited a cardiologist here, and we can't leave heart health out of our discussion today. Let's talk about heart health. How do we keep our heart healthy? So if it's not the fat that's causing heart disease, what is it?
Well, again, it's not one thing, right? But so you could say eating fat is related, in the sense, if you're overeating fats and carbs and calories, then okay, that's implicated in increasing weight, increasing insulin resistance, and decreasing metabolic health, and increasing cardiovascular risk. That is all clearly related. But you can certainly get there eating very little fat and tons of carbs, and overeating carbs and sugar, and you can get to the same place, right? So it's clearly not just the fat, if you can get to the same place doing it that way. So I think one of the biggest changes that I'm starting to see is people being more aware that metabolic health is cardiovascular health, that they're one and the same, right? Cardiovascular health for decades has been LDL and dietary fat. And like, that's cardiovascular health. No, not at all. Not at all. It's really metabolic health is probably first and foremost. And lipids, especially LDL, are going to be secondary, if not tertiary. Not that they have no role. They certainly have a role. But, there's this great study, a retrospective analysis of the Women's Health Initiative. And it was, I forget, like a 20-something year follow-up. And they looked at what were the conditions present at baseline that predicted the development of cardiovascular disease the most? And LDL was on there with a hazard ratio of like 1.4. So not 0, not 1.0, but 1.4. ApoB was a little better at 1.9, and ApoB is just a better lipid marker than LDL. But this measure of insulin resistance was at like 6, and type 2 diabetes was at 10. So, I mean, like, if that doesn't help put things into perspective, I don't know what does. That metabolic health is cardiovascular health, and that's what we really need to focus on. And then, but also factor in lipids as they play into it. And lipids meaning HDL, triglycerides, VLDLs, small dense LDLs, and LDLs, right? All those things are under the umbrella of lipids, and they all matter. So and of course, blood pressure matters, right? Inflammation matters. Like, all these things are part of cardiovascular health. So when you say, how do we improve cardiovascular health? Well, you find a way to fix all that. You find a way to normalize all that. For some people, a low carb diet along with exercise is going to be a fantastic way to improve every single one of those markers.
So how did we come to blame LDL? I mean, even there are obviously the lower density sort of LDL particles, and then there's so let's go into the details and how we came about, blaming, HDL is the good one, which we don't doubt, but people are now starting to doubt whether LDL.
Actually, people are doubting whether HDL is the good one too. So again, it all comes down to observational data, observational science. That if you go back to the Framingham study, you look at total cholesterol, or then other studies, you look at LDL cholesterol, and it correlates. Those who had higher total cholesterol or higher LDL cholesterol had a higher risk of developing cardiovascular disease. Those who had lower HDL have a higher risk of developing cardiovascular disease. Again, is it a dramatic blow your socks off kind of increased risk? No, it's a small signal, but the signal's there. But then again, you have to say, who is the population we're looking at? And it's a general population eating a high carb, high fat, high calorie kind of diet. They most likely all have some version of metabolic dysfunction. What wasn't measured in the majority of the trials, so we don't know. But when you correlate for HDL and triglycerides, which are good surrogates for whether or not you have metabolic dysfunction or not, now all of a sudden LDL becomes much less important. And again, not that it's not important, but it becomes much less important. So an elevated LDL with somebody with type 2 diabetes or somebody with high triglycerides and low HDL is more of a concern for me than an elevated LDL with someone with normal insulin sensitivity, low triglycerides, and normal to higher HDL. Again, put it in perspective. There are other things that would make me concerned about that that elevated LDL, even in that metabolically healthy patient. But boy, it's a lot less of a concern than it is in that metabolically unhealthy patient. And so that's the differentiation I think we have to start to make and evaluate people more holistically. That's kind of a dangerous term sometimes, but from a broader perspective. And then, what's their calcium score? What's their family history? What's their blood pressure? Do they have a history of smoking? All of these things come into play to say how important do we think your risk factors are. But that's a complicated discussion, right? Would that take me 2-3 minutes to describe, as opposed to being in a doctor's office and saying your LDL is high, we need to bring it down to improve your heart health. That took 3 seconds, right? So much easier to say, to understand, to do, but I don't know that that's doing our patients a whole lot of good. And
also because there's a drug to lower LDL. So it's easier to recommend that and give the drug, prescription for the drug. Okay, so how dangerous are the triglycerides?
Well, triglycerides are dangerous, I guess you can say, from a couple different reasons. One, they appear to be independently correlated with increased risk of cardiovascular disease. So what that means is, above and beyond anything else going on, if your triglycerides are high, there's a higher risk of heart disease. But the second reason they're dangerous is because they are associated with metabolic dysfunction, with insulin resistance, with prediabetes and type 2 diabetes, and with increased VLDLs and hyperinsulinemia, right? High triglycerides are associated with all those other features. So they're a marker of poor metabolic health, which is also why they're dangerous. So, the normal, quote unquote, normal triglyceride is set at 150 milligrams per deciliter. And sorry, I can't do the math off my head to do the.
I'll convert it. That's okay.
Yeah, but But from my practice, people I see in my practice, I'd like to see them below 100 or even lower. I want to look at the triglyceride to HDL ratio to get that around 1.5 or less. You know, so it depends how aggressive you want to be, but it's clear that addressing triglycerides and helping lower it with lifestyle, not necessarily with drugs, but with lifestyle, is going to be one of the most important things you can do to help people.
So can we say that a ketogenic lifestyle, or a generally low carbohydrate lifestyle, it doesn't have to be very strict for everyone, that improves your metabolic health, will also improve, have a direct impact on your heart health? Can we just summarize?
So glad you asked this question. So I'll timestamp this. We're recording this on Friday, September 16th. I'm not sure when it'll be published, but just today I released a video on Diet Doctor about keto diets and heart health, and how keto diets can improve heart health. Now, with caveats, right? So first, in this video, I talk about why there's this misconception that keto diets harm heart health, and how they're like automatically dangerous for cardiovascular health, which is totally not true. So I go over that in the video. But then again, a trial like Virta Health and a small study like with Dr. Tro, what they were able to show was that the calculated cardiovascular risk went down when people started a ketogenic diet. So the intervention was a keto diet with, connections with a health coach or a physician. And for Virta Health, it was for a year. For Dr. Tro's study, it was 6 months. Their calculated cardiovascular risk went down. So does that prove it reduces heart attacks, reduces heart events? No. Again, for that, you need a 10, 15-year study. But the tool that all cardiologists are taught to use to assess someone's cardiovascular risk decreased in both those studies. That's pretty powerful.
Interesting. Then I'll look out for that video and put the link below as well.
Mm-hmm.
Okay, so when it comes to diabetes, what bothers me or what saddens me is that most people think that they've been super healthy, and then they go to sleep one day and wake up with type 2 diabetes the next day, because they are not warned enough. They're not given enough warning. Their insulin levels, for example, aren't checked. So it takes 15 to 20 years to be hyperinsulinemic and then become type 2 diabetic. So how do you explain this to your patients with regards to heart health? Because I'm sure no one ever goes to sleep completely super healthy and wakes up attack the next day. How do you prevent that from happening? Because we need to prevent it, right? I mean, we need to go back.
Absolutely.
Yeah.
Absolutely. Yeah. And that's part of this thought, that if LDL is your only focus, and all you're looking at is a high LDL, and then one day you have to treat the LDL. Oh, I'm treated, I'm fine. I don't have a heart risk anymore because I'm treating my LDL. Like, that concept has to get thrown out the window. And exactly like type 2 diabetes, your fasting blood sugar could be 98, which is normal, but it could be 98 with an insulin level of 2, or it could be 98 with an insulin level of 42, right? And those are completely different scenarios. And so I guess the analogy for cardiovascular health is, you're not just looking at the LDL, you're looking at the HDL, triglycerides, blood pressure, and you're looking at lifestyle in general and what they're doing. So it's really trying to factor in all these health factors. And what are you using to measure risk? Are you just using a surrogate like LDL, or are you getting a coronary calcium score, which actually tells you if you have plaque in your arteries, which is such a more powerful test than just LDL. Now, it's not perfect either, but so much better to measure sort of more of an end result than just a surrogate marker.
So talking of all these sort of different tests, or preventative tests, or exams at least, why is it that we don't routinely check, or at least annually, or once every 2-3 years, a detailed lipid panel, for example, a more detailed one? I've never had one done because it's not offered by the British National Health System. We just do the basic ones and that's it.
Yeah. Well, because if your biggest concern is LDL, that's all you need. And if your treatment of choice is a statin, that's all you need, right? If you want to know what type of effect lifestyle interventions have on lipids, then sure, measuring your small particles is really important. Measuring your VLDL is very important. Looking at your ApoB is so important. So, but if all you care about is what's your reaction to statin, and do you need a statin or not, then And I guess LDL is all you need to measure. So that's why. I mean, it's unfortunate. And the same for calcium scores, right? Like, why are people getting calcium scores routinely? Well, there's fear of radiation, but a calcium score is such low radiation, like 1 millisievert or less, depending on where you get it done. Doesn't mean you want to get one every month, of course, but to get one as baseline and then get one a year or 2 or 3 or whatever later to see if there's progression. I mean, it makes sense if you're worried about your cardiovascular health, and you want to make sure whatever radiation you're getting that is going to help impact your understanding of your health risk and the potential treatment, whether medication or lifestyle. So if that's the case, I'm a big fan of more people getting calcium scores.
So who do you recommend the CAC test for? What sort of...
Is everybody too broad? Is that too broad of an answer? Everybody? I mean, look, probably 40-year-old and up, right? If you're under 40, the validation of calcium scores is not well done, and chances of it being anything but 0 are so low that maybe it's not worth it, except strong family history, or you've already had type 2 diabetes, or you've been a big smoker, or you have familial hypercholesterolemia, something to significantly elevate your risk then at a younger age. But 40 and above, probably a good idea, certainly 50 and above. And certainly anybody who says, look, I want to make a change in my lifestyle now and see what effect it has over time. How do I measure that effect? Calcium score is a great way to do it.
I was just trying to figure out if I need to go for one too. Approaching 50, I've never had one done. But then there's type 2 diabetes in my family, not necessarily heart attacks, but type 2 diabetes runs rampant.
Well, and with type 1 diabetes, your risk is certainly higher for cardiovascular disease, right? Like, I'm sure you're under outstanding control now, but like you said, 20 years ago when you were told to eat whatever you want and cover it with insulin, and people's goal A1C is 7, that's like perfectly good and acceptable, and A1C is 7, that's nowadays that should be total mismanagement when you can get it down to 5.5 or lower perfectly safely with nutrition and medications. So people with type 1 are at higher risk, and so I think they should get calcium scores.
So if a certain level of plaque is detected in the arteries, can that be reversed? Do we know if it's reversible, or just that we can stop it there and then so that it doesn't progress further?
Yeah, I think reversing cardiovascular disease is a fool's errand at this point, and especially reversing coronary calcium score, because the calcium is the sort of body's healing response to a vascular injury. So it shows you there's been vascular injury and plaque there. So I don't know that we want to reverse it, but what we want to do is make sure, one, that any soft or vulnerable plaque that exists is calcified. So in that sense, increasing the calcium score can be beneficial to a degree. And that's like, totally blows people's minds to a degree. But that's when we're talking about a very different scenario. We're talking about a person with known soft plaque. If you can turn that into calcified plaque, that's a net benefit, most likely. But also, you want to make sure no new lesions pop up. So if you have a calcified plaque that becomes more densely calcified, that could be a positive thing as well, as long as the calcium is not invading the lumen of the artery. But a more densely calcified single lesion could be a sign of benefit. But a new calcified lesion that popped up somewhere else is what you want to prevent. So it's a more complicated discussion than just to say, do you want to reverse the calcium score or to stop progression or whatever. You need a little more detailed analysis. But I think trying to slow the progression is the right approach, as long as it's the progression of new stenoses, new plaques, or invasion of the lumen of the artery with that plaque. And for that one, you need a CTA, though. The calcium score won't show you that.
So can we say that, the type 1s are equally vulnerable when it comes to heart health, because usually we think of type 2s, but type 1s can easily fall in that category too. Sure. Can we then say that lower insulin levels in general, of course, given the sort of context of the person, age, muscle level, etc., but generally lower insulin levels and better control of glycemia or normal glycemia, whether you're diabetic or not, as long as these are controlled, then your risk reduces?
Yeah, it's a great statement. And I agree 100% with that statement. Now, do I have data to show that in someone without diabetes or pre-diabetes, that normalizing their insulin and normalizing their glycemia improves their outcome? I don't, data doesn't exist for that person. Not either way, right? It just hasn't been looked at. It doesn't prove that there's no benefit, but it doesn't prove that there's a benefit because it just hasn't been looked at. So I have to be honest and say that's sort of my gut instinct and kind of taking what data is out there and making my best guess. But absolutely, I think it's definitely important. But so does that mean, an A1C of 4.9 is substantially better than an A1C of 5.2? Probably not. Probably not. Does it mean, a maximum rise of your blood sugar to 105 is better than a rise to 115 if they both come down to baseline within half an hour? Probably not. Like, that degree of difference is probably not a difference. But is a 4.9 better than a 5.6 for A1C? Okay, yeah, there I'd say probably yes. And is a 110 better than a 135? Especially if that 110 comes down in half an hour and the 135 takes 90 minutes to come down, both considered normal, by the way. But yeah, to me, that makes a difference. So, it's a moving target to a degree, but I think there is a difference there.
What I've always been interested in, and again, there isn't a definitive answer to that, and I don't expect you to give me one because I know that there isn't, but I'm interested in your thoughts that it isn't necessarily where your baseline blood sugars are that's having an impact on your general, including heart health, but general metabolic health, but the daily and constant variability, the ups and downs and the ups and downs. I mean, I know that ruined my health. It wasn't necessarily the high A1C per se, but it was the fluctuations. And there was no way I could control it. I stopped checking my blood sugars because I knew they would always be high or higher.
Yeah. I mean, I think it's both, right? If you have a baseline of 85 versus a baseline of 120, that's a big difference, right? And if you have glycemic variations of 60 points versus variations of 30 points, that's a big difference. So I think they both have a role. Now, what's interesting is I think we've sort of ignored the glycemic variation for a long time, and it's becoming sort of more noticeable and more recognizable with CGMs, and people are starting to pay more attention to it, which I think is good. But I don't think that means we can ignore the baseline of your blood sugar either. I think they both play a significant role.
The baseline is important, and so many people who are not diabetic, for example, exhibit sort of graph CGM when they wear a CGM. Their baseline is so higher than what I would consider normal, for example, being a type 1, but they're just under the illusion because they haven't yet been diagnosed as type 2 diabetics. So they're under the illusion they're super healthy. How do you explain to those people, for example, who are exhibiting worrying fluctuations in their blood sugars, wearing a CGM, but they're not diabetic?
Yeah, I mean, that's a great question. And it's like you can do your own glucose tolerance test just by wearing a CGM and eating meals and seeing how you respond. And if you have an elevated fasting sugar that stays elevated during the day, it's something you definitely need to pay attention to. Now, where it gets confusing is the people who have this dawn effect, where they are sort of elevated in the morning to like 110, 115, but that's the highest they see all day long. And after they eat, it comes down actually, and then they're in the 80s and 90s the rest of the day. That's very different for someone who's in the 110s, 115s all day and goes up with meals from there. Those are two very different scenarios. So that second scenario absolutely is basically, in my mind, has diabetes. They don't fit the definition maybe for type 2 diabetes, but in my mind, they need to be treated as if they have type 2 diabetes, because if they don't now, they will soon.
Dave Feldman once called it blood sugar dysregulation, because that's exactly what it is if you're having the highs and lows.
Leave it to an engineer to give it a name that actually makes sense.
It makes so much sense, and I quite like the sort of the terminology he used. We're going to talk about or wrap this up very, very soon. I'm aware we're running out of time, but how important is exercise for general metabolic health, but particularly heart health? Because you're interested in fitness and improving people's fitness. So let's talk about
Absolutely. Yeah, absolutely. I think exercise has certainly gotten a bad rap, I guess you can say, because it's not the best thing to help with weight loss. Now, it can help with weight loss maintenance. It can help with the type of weight loss. Make sure you're losing fat mass, not lean mass. but it's not like the number one thing to do for weight loss. So because of that, people start to think, oh, well, exercise is not that important. But that's not true either. I mean, it's very important for cardiovascular health. And whether you're talking about observational studies or interventional studies with surrogate markers, exercise does make a difference. It lowers blood pressure. It can lower long-term inflammation. It can improve blood sugar regulation and lower insulin and improve triglycerides and raise HDL. Like, it does all the things that you want to do to improve your cardiovascular health. And then just improving your VO2 max and cardiorespiratory fitness also correlates with improved cardiovascular health and decreased cardiovascular events. So many lines of evidence point to exercise being very important for cardiovascular health. But then, of course, the next question is what type of exercise? And there, I mean, the answer truly is whatever you're going to do, right? Because again, if you're told one thing is great, but you're never going to do it, then it's not great for you. But if I could design one exercise program for everybody, it would be one day with, pretty hard resistance training, then one day with zone 2 cardio training, then one day with interval training, and then one day maybe with mobility training, then one day back to resistance training, then one day back to zone 2. And then I would get all these different types of exercises in there. I think that's ideal. Are most people going to be able to do a program like that? No, of course not. But they have to find a program that's going to work for them that incorporates those basic principles.
Mm-hmm. And so this is when I think good or well-qualified personal trainers come into the equation. Some people need that support.
Yeah, absolutely. And that's one of the things I did that a lot of people thought I was crazy was, as a cardiologist, I went back and got my certification as a personal trainer. People are like, what? You're a cardiologist and you're going to class and training to become a personal trainer? And people thought I was crazy, but it was one of the more valuable things I've done, because it really helped me give exercise prescriptions, individualized exercise prescriptions to my patients, which I think is so valuable. And yes, we need more people doing that, and not just saying exercise more, move your body more. Like, what does that mean for most people? They don't know. People need guidance. Yeah.
I like that you call it exercise prescription, because
That's what it is.
We usually associate prescription with pills. So, so you must find yourself de-prescribing medication as well.
Yeah, that's one of the most rewarding things I think a doctor can do, is de-prescribe. And 10 years ago, I don't think I ever heard anybody use the term de-prescription or de-prescribe. And now it's just so commonplace in this community, and it's so rewarding. One of the most rewarding things I do.
And it's a serious affair. I can call it that. It's not in medical books.
Yeah.
It's not in medical books. So
no, it helps the patients feel better. It saves them money, and it gets rid of side effects, and just makes life better. So why is that not being promoted everywhere? I don't know.
Dr. Scher, what are some of the medications, very, very briefly, that you find yourself de-prescribing?
Well, insulin's the easiest one. I mean, that's, of course, not for someone with type 1, but you can lower the dose. But for someone with type 2, insulin is far and away the easiest. Blood pressure medicine all the time, for sure. And other blood sugar medications, whether it's like SGLT2s or sulfonylureas or even GLP-1s, which are so popular right now. Being able to de-prescribe those is wonderful. Sometimes even like gout medications, we can de-prescribe. And, frequently if I see someone on a constellation of different lipid medications, sometimes maybe they're on like something like Tricor for their triglycerides. Those are usually very easy to de-prescribe as well. So yeah, a number of different ones can really quite easily be de-prescribed. Proton pump inhibitors, people who had a whole lifetime of heartburn, they changed the way they're eating, and I don't have heartburn anymore, and get them off those prescriptions. And antidepressants with more caution, for sure. I liken that to sort of like insulin. You have to be very careful about de-prescribing, but that's possible as well.
Dr. Scher, how can people reach you, support your efforts?
Yeah, thank you for asking. So I guess a couple places. I do still see patients in a telemedicine practice. So lowcarbcardiologist.com is the website there. All of my videos and podcasts are on YouTube for the Diet Doctor YouTube channel, or just any of your favorite podcast mediums. And then of course dietdoctor.com, where we have most of our educational guides that I've written or edited or are medically reviewed. So those are the best ways to kind of find out more.
I thoroughly enjoyed our discussion today. So thank you once again for accepting my invitation.
My pleasure. I'm so glad we ran into each other at the conference, and thanks for the invite.
Thank you so much. Bye for now. you.